In the previous two latest videos that I have uploaded on my channel related to the breast, I have extensively discussed the anatomy, histology and lymphatic drainage of breast. So, moving further with this series related to the breast, I will be discussing the cancer of breast, incorporating the knowledge of its anatomy, histology and lymphatic drainage discussed in the previous parts. So, I request the viewers to watch my previous two videos to correctly understand this video. I have shared the links of the previous videos in the description of this video. Breast cancer is a disease in which cells in the breast grow out of control. Breast cancer is not an isolated disease that manifests itself as a discrete entity from other diseases of the breast that are not cancers but precursor stages for cancer. Breast cancer can begin in different parts of the breast. A breast is made up of three main parts: lobules, ducts, and connective tissue, which I have outlined in the details in my previous videos. The lobules are the glands that produce milk. The ducts are the tubes that carry milk to the nipple. The connective tissue, which consists of fibrous and fatty tissue, surrounds and holds everything together. So, most breast cancers begin in the ducts or lobules. There are several types of breast cancers. I will not be discussing the less common types here. So, the two most common types of breast cancers are invasive ductal carcinoma and invasive lobular carcinoma. Talking about the invasive ductal carcinoma, the cancer cells begin in the ducts and then grow outside the ducts into other parts of the breast tissue. Invasive cancer cells can also spread or metastasize to other parts of the body. Next, talking about the invasive lobular carcinoma. Cancer cells here begin in the lobules and then spread from the lobules to the breast tissues that are close by. These invasive cancer cells can also spread to other parts of the body. Invasive ductal carcinoma and invasive lobular carcinoma, each of them has a precursor stage called the ductal carcinoma in situ or DCIS and lobular carcinoma in situ or LCIS, respectively, which can together be called the non-invasive breast carcinoma. Non-invasive breast carcinoma arise from the terminal duct lobular unit, which can be seen here. Ductal carcinoma in situ or DCIS is a breast disease that may lead to invasive breast cancer. These cancer cells are only in the lining of the ducts and have not spread to other tissues in the breast. However, DCIS is commonly associated with infiltrating ductal carcinoma. DCIS is frequently multifocal and bilateral. The involved ducts are distended by malignant cells and central necrosis is a common feature. Here, you can see the DCIS filling, distorting and unfolding the involved lobule and thus appears to involve duct-like spaces. It is confined by a basement membrane and is not invading into stroma or lymphovascular channels. If it does, then it would turn from non-invasive to invasive ductal carcinoma, which we will see later. When invasive cancer does develop, it is usually in the same breast and quadrant as the earlier DCIS. On cutting through the tumor, gentle pressure on the transacted ducts extrudes toothpaste-like necrotic tissue. Calcification is a common feature. Consequently, DCIS is detectable by mammography. DCIS, according to the size of the nucleus of its cells, can be classified microscopically as low and high nuclear grade. The DCIS seen here has a high nuclear grade identified by cells having large nucleus. In contrast, as you can see here, the LCIS, like the low nuclear grade DCIS and unlike high nuclear grade DCIS, has a uniform appearance with cells having monomorphic round nuclei. LCIS is a neoplastic proliferation of lobular epithelial cells that fill and distend all the acini of at least one complete lobular unit, obliterating their lumens, as is also seen here. Also, you can see here that in contrast to DCIS, the LCIS usually expands but does not alter the underlying lobular architecture. LCIS, similar to its ductal counterpart, is seen confined by a basement membrane and is not invading into the surrounding stromal tissue. LCIS, similar to DCIS, tends to be multifocal and bilateral. LCIS, in contrast to DCIS, does not produce a palpable lesion and is not apparent on mammography. It is usually an incidental pathologic finding in a patient who has had breast tissue removed for some other reason. Now, I will talk about the invasive breast carcinoma, which all of us commonly refer to as breast cancer. The most common invasive breast carcinoma is invasive ductal type. Most ductal carcinomas form a hard, palpable infiltrative mass which on cutting with a knife is gritty, rock hard, grayish white in color and extends irregularly like a claws of a crab into the surrounding fat. The replacement of normal breast fat by this dense tumor is visible as dense areas in mammography. Microscopically, as seen here, the cells look similar to DCIS, but in contrast to DCIS, you can appreciate that now the tumor cells have crossed the basement membrane and invaded the surrounding breast tissue. Advanced cancer may cause dimpling of the skin, retraction of the nipple, or fixation to the chest wall. You can appreciate the dimpling of the skin here. It is due to inward pull of the fibrosis caused by the cancer. One can also appreciate the ulceration of skin caused by the cancer extending to the skin. In this view, the nipple appears retracted and inverted. This is caused by extensive fibrosis surrounding the cancer, which has dragged lactiferous duct seen here and in turn retracted the nipple along with it. In this view, you can see an invasive ductal carcinoma piercing the pectoralis fossa and invading the pectoralis major muscle, which causes the fixation of tumor mass to this chest wall, an important clinical sign used to differentiate a non-cancerous breast mass from a cancerous one. Now, moving on to the relatively less common type of breast carcinoma, the invasive lobular carcinoma, which consists of cells morphologically identical to the cells of LCIS, which you can very well appreciate here. The cells invade individually into stroma and are often aligned in strands or chains. The cancer usually presents as a poorly defined area of induration that may remain undetected by inspection as well as palpation. The spread of breast cancer occurs through two pathways. The common one is the lymphatic pathway, and the not so common is through the bloodstream. Talking about the lymphatic route first, here you see a cancer cell traversing wall of lymphatic vessel. The cancer cells then follow the lymphatic flow to drain into respective sentinel node. A sentinel lymph node is defined as the first lymph node to which cancer cells are most likely to spread directly from the site of origin of the cancer. About 75 to 90% of the overall breast lymphatic flow drains into the same side axillary group of nodes. The internal mammary nodes come second, receiving 10 to 25% of breast lymph, while approximately 5% goes into the posterior intercostal nodes. Lymphatic spread allows predictable routes according to the site of the primary cancer. The axillary lymph nodes receiving a major lymphatic drainage share makes it the most commonly involved node in the spread of cancer. Cancer breasts located in the upper outer and part of the lower outer quadrants drain primarily into these axillary nodes. The axillary lymph node chain may be divided into 5 groups, namely the anterior, posterior, lateral, central, and finally the apical axillary nodes. The apical nodes are the final common pathway for all other axillary lymph nodes. Here you see the cancer cells involving one of the exterior axillary nodes. Spread beyond the axillary node into supraclavicular and cervical nodes is evidence of advanced disease. The supraclavicular nodes receives the breast lymphatics through the apical group of axillary. Further up, the supraclavicular lymph nodes drain finally into the brachiocephalic veins. The nodes along the internal mammary artery may be involved in carcinomas located in the medial half of the breast. A detailed description of the lymphatic drainage has been outlined in my previous video made specifically for the lymphatic drainage of breast. If required, please refer to that with the link given in the description of this video. Now in this view, you can see a group of cancer cells metastasizing into breast lymphatics and blocking the flow of lymphatic fluid. The lymph vessels appear dilated and tortuous because of blockage of lymph flow. The local dermal lymphatic obstruction, most commonly due to the extensive axillary node involvement, causes edema of skin called peau'd, which means skin looks like the skin of an orange fruit. Here you can appreciate the skin of the cancerous breast with the appearance similar to orange skin. The spread of breast cancer through bloodstream is less common than through lymphatics. Bloodstream metastasis can be in the bone, liver, and lungs. It occurs in the later stages in almost all cases, not cured by initial treatment. Entry of cancer cells into the bloodstream occurs early in the course of invasive breast carcinoma, but most of these cells are either killed by the immune system as seen here or remain dormant in distant organs. Now, I will be telling some of the salient points which are important to remember about breast cancer. Most patients of breast cancer present with a painless mass. Any breast mass should be regarded as a carcinoma until proved otherwise. A few patients present with a bloody nipple discharge. Early detection of breast carcinoma is very important because the smaller the lesion, the greater the likelihood of cure. Self-examination of breast is strongly recommended at monthly intervals for all women. Mammography is capable of showing breast cancer at a stage before it is palpable. Mammography is highly recommended for high-risk groups such as patients with a family history, a previous breast biopsy showing atypical hyperplasia, or a previous history of breast carcinoma. It is also recommended for all women above the age of 40 years. The risk of cancer is high in nulliparous women, in women who have early menarche and late menopause, and in those who have their first pregnancy after the age 30. All these factors lead to prolonged estrogen exposure. Estrogen is believed to promote carcinogenesis by stimulating the cancer cells to secrete growth factors that promote the tumor progression. Breastfeeding appears to have a protective effect for the mother. A family history limited to first-degree relatives, that is mother, sister, or daughter, of breast carcinoma increases the risk fivefold. Mutation of the BRCA1 and BRCA2 gene located on chromosome 17q and 13q has been reported as important in families with a high incidence of breast cancer. According to Centers for Disease Control and Prevention, some warning signs of breast cancer are here as follows: new lump in the breast or underarm, thickening or swelling of part of the breast, irritation or dimpling of breast skin, redness or flaky skin in the nipple area or the breast, pulling in of the nipples or pain in the nipple area, nipple discharge other than breast milk including blood, any change in the size or shape of the breast, or pain in any area of the breast. Keep in mind that these symptoms can happen with other conditions that are not cancer.